Lovely. So welcome everyone to today's Lunch and Learn about the brush toolkit. We've got Cara, Zoe and Peter with us today. I'm going to record this session and it'll go on our YouTube channel by the end of the week. And we're also going to send the slides round. If everybody could mute themselves, that would be fantastic. And we'll keep an eye on that during the meeting. So if you do suddenly get muted, it's probably because Nicola or I have muted you. Please feel free to put anything in the chat. We'll keep an eye on that. And there'll be some opportunities for questions at the end and we'll keep an eye on that for you. So over to you, Brush team.
Thanks, Kate. Thank you very much for your kind introduction and for inviting us tonight for lunchtime. So we're talking about all things brush, and Zoe and Cara are here with this as well. So we've split our talk up into 3 different bits. I think we'll probably each introduce ourselves as we come on with the different bits that we're going to talk about rather than doing an introduction up front. So my name is Peter Day. I'm one of the paediatric dentists working in Leeds and Bradford. And I'm just going to touch base and explain why is dentistry in the news at the moment and what the current child oral health profiles look like, and therefore why there is a need and importance around how we can improve children's oral health. So off we go. I'm just going to check. I'm looking at everybody just to make sure that we're moving a slide. Yep, I'm getting Kate's got fingers up. Excellent. Right. So this is just to give a little bit of context. This is the national data. So every 2 or few years they run a dental survey, or every year they run a dental survey, and it alternates between different age groups. But back in 2020, so this was during the pandemic, so the data is slightly impacted by the pandemic, but they looked at 3-year-olds and they looked at the number of 3-year-olds who had dental decay. And you can see that the national, so 1 in 10 3-year-olds had dental decay. In Yorkshire, it was up to almost 15%. And the highest scoring local authority was in the north, was Salford, at 27%. If we look at a more recent survey, so this is the 2022 5-year-old dental survey, you can see that by 5, approximately 1 in 4 children have dental decay. Yorkshire's figure is a little bit higher, and one of the highest areas in the country was Liverpool, with over 2 in 5 children having dental decay. So to summarize, at an average level, and certainly in the north of England, it's higher, but 1 in 4 children has dental decay. Also, for those children who have dental decay, they're walking around with 3 or 4 decayed teeth. So it's not just a single tooth, but it's 4 teeth in their mouth have got decay, and it's 1 in 4 children. And if we look at the data year on year, you can see that the data is slowly improving, but there was a good drop, from 2008. But more recently, the data has stagnated, and you can see that actually, the last 5-year-old dental survey, which is what this is reporting, was again at 23.7%. So it is stagnated. And, if we use a health inequalities lens, this is a deprivation graph. So the most deprived are on the left-hand side, the least deprived are on the right-hand side. And you can see that children in the most deprived decile were most likely to have dental decay. And you can see quite a marked slope down the deprivation scale. And also, with this lens, certain ethnic groups are more likely to have dental decay. And you can see here, this is again the 2022 5-year-old survey, that children from an Asian background and from an other background were more likely to have decay. And I think other includes quite a lot of children from an East European background, but not exclusively. So what's the impact? What's the impact of children, every 4th child having dental decay? Well, certainly there's some obvious things around toothache, impaired sleep, difficulty eating. But obviously, there is also a wider impact on the family and time off school, time off work to take children to the dentist, and also disruption to wider family life. There's some impacts on schooling and children being off school because of either dental problems or dental treatments. And there's a significant cost for hospitals. Dental decay is the most common reason why a child in the UK will have a general anesthetic for the 5 to 9-year-old group. And certainly all the data is around childhood admissions for dental reasons. And that costs the NHS at least £50 million per annum. The good news around dental decay is that it's almost entirely preventable. And there's clear guidance on what behaviours and activities can reduce or prevent dental decay. And that's around limiting sugary foods and drinks and getting fluoride on the teeth. And the most obvious way of getting fluoride on the teeth is through toothbrushing in a home setting. And where those behaviors are set up in early life, then the impact is quite significant. So this is a study by Hall Scullin. It's a cohort study of about 6,000 children in the Northwest. And there's two lines here. The top line is for the children who had dental decay in their primary teeth at the age of 8, and they were then followed up until the age of 15. And the bar on the y-axis, so going up the page, is the number of decayed teeth. And you can see that if you had decay in your permanent teeth, then there is quite a steep trajectory, and those teeth, the higher chances of getting decay in your permanent teeth. So you can see they're followed up at 11, 14, and 15. If you had no decay at the age of 8, you can see the chances of having decay in your permanent teeth at the age of 15 are very much reduced. And you can see that the two trajectories are separating, and highly likely that they will continue to separate into adult life. And so one of the key findings of this study is that if we can set up good behaviors in early life, early childhood, then we have significant impact, not only just for those young children, but across the life course, and especially across childhood into adult life. So if we can set up these good habits, then it has a significant long-term benefit. There are different ways to improve children's oral health, and often these are described as upstream. So that might be water fluoridation, it might be sugar taxes. Midstream, which is activities at a place-based setting. So that will certainly be supervised toothbrushing, which we're talking about now. And downstream is more those conversations and those individual behavior changes that we might have at the dentist. And so we're going to talk about today probably one of the most impactful activities to improve children's oral health. And supervised toothbrushing, as Cara and Zoe will explain, is around activities that take place in the classroom or the nursery where children are supervised by a teaching assistant or other member of staff to actually brush their own teeth. This is some data from Scotland, the Child Smile programme. But importantly, you can see that children from the most deprived quintile in this group were highly likely to take part in these activities. You can see 94%. And for those from that most deprived quintile, the benefits were seen within a year. You can see there is a significant reduction in dental caries from about 50% down to about 45%. For the next quintile up, that impact was seen within 12 to 24 months. And for all quintiles, there was a benefit if there was supervised brushing on that daily basis at school within 36 months. And then finally, from my point of view, when we look at return on investment, and this is data from Public Health England, and you can see that for the supervised toothbrushing programs, that for every £1 spent, there was a return of investments of about £3 after 5 years and a little bit more after 10 years. So clear evidence of benefit for those children who take part in supervised toothbrushing. And importantly, those from a most deprived background have the most benefit from these activities. There is importance placed on improving children's oral health, both from an NHS activity and programme point of view, with the core 20+5 child and young persons priorities, with oral health being one of the 5 clinical areas. And at a early years setting, there is clear guidance from the Department for Education that oral health activities should be included within that curriculum. So those are a couple of documents and national guidance which help support these activities. I'm going to leave it to Cara to now come on.
Thanks,
And I'm
Peter.
hoping Cara will appear.
Can you hear me? Perfect. Thanks, Peter. So I'm Cara Gray-Burrows. I'm a lecturer in behavioural sciences and complex intervention methodology at the University of Leeds. I'm just going to talk through the research we've done as part of the BRUSH project. So Peter's done a great job setting the foundations around supervised toothbrushing and its effectiveness, but it hit the news very recently when Labour pledged that they would have a supervised toothbrushing programme if they were to be successful in the general election. And next slide, Peter. We've written a... Ooh, the slides are not moving for me. I don't know if they are for anyone else. Perfect. We've written a conversation piece about that. And if you scan the QR code, you can read more about that. So essentially, next slide, Peter. Supervised toothbrushing programmes are coming up more and more, particularly with the media attention and the policy push for it as well. But they're not new. So next slide, Peter. They already happen on a national scale in Scotland with Child Smile and in Wales with Design to Smile. And they do already happen in England. It's just that their uptake and implementation is incredibly varied and sporadic. And that's where the BRUSH project comes in. Next slide, Peter. So with the BRUSH project, we wanted to explore the variation in toothbrushing programmes across England and identify what were the successful determinants to implement these programmes to increase uptake, sustainability, and ultimately the impact on children's oral health. Next slide, Peter. And we've done that within the BRUSH project using a variety of methods, so I'll go through them all in more detail in a bit, but essentially it comes down to a survey of toothbrushing programmes, qualitative interviews with key stakeholders, co-design of an implementation toolkit, and pilot testing and implementation toolkit. Next slide, Peter. But before I go into kind of the methods we've used, just to break down the intervention and its implementation a little bit more to set the context, the intervention itself, in reality, is quite simple. It's purely children brushing their teeth. It's getting fluoride, which we know helps reduce tooth decay on children's teeth. Where the complexity lies is in its implementation and delivery. Next slide, Peter. And that starts first with the number of key stakeholders that are involved with the implementation of these programmes. So as you can see, there's a whole raft of actors that have to come into play and work together to make this intervention happen. And they're all operating within their own local context and within their own systems. So this is high level from commissioners to oral health providers, all the way down to the early years settings themselves, so the nurseries and schools and childminders, the parents, and of course the children. Then you have to factor in, next slide, Peter, that there's lots of different delivery models for this intervention, centering around 3 key areas: funding, training, and provision. So in terms of funding, they can be funded by lots of different sources. It might be local authority, it might be NHS England, it might be a charity. It can be, in some cases, that some settings self-fund the programme. Then there's the training to consider. So before you can do this intervention, you have to have adequate training. Again, this could be provided by a number of different people. It could be provided in person or online. And then this training must cover not only what you must do, but also has to cover key concepts in terms of cross-infection and quality assurance. And then finally, there's the provision. So these are the actual supplies and tools you need to deliver this intervention. Again, this can be provided by a variety of organisations. So next slide, Peter. as you can see quite quickly, this very simple intervention becomes complicated due to the number of actors involved in it and the number of different delivery models. And depending on the local context and situation and system, it might be that different activities are performed by different key stakeholders. And so the real key focus of this project is we wanted to unpick this complexity in order to really try and simplify it and share good practice and resources so that if there ever was a national programme, for example, or just even regional programmes, it would help people implement this programme in a much more efficient way. And as I've already kind of hinted, the kind of end goal of this was to create some form of implementation toolkit that does bring together shared practice and resources that could be shared and adapted to each local context. So next slide, Peter. So in terms of the research, the first thing we need to do is we really need to see what the current provision of toothbrushing programmes were across England. So we undertake a stock take survey, and we had responses from 141 local authorities, and roughly there was a 50-50 split on the uptake of toothbrushing programmes, with the majority of these being commissioned and majority of them being targeted, namely by deprivation level and tooth decay levels. Next slide, Peter. So we created, our colleague Tom Broomhead created these lovely maps that kind of outline where these toothbrushing programmes are, and you can see the number of children and things like that. And he's working on creating these interactive maps that we're then going to share on our toolkit later, so you'll be able to get the local data for your area. And next slide, Peter. But also, as part of this, when we did our stock take survey, we wanted to find out if we could get a little snapshot of some of the barriers and facilitators that people were finding at this kind of local authority level for the implementation of toothbrushing programmes. And as you can see, there's a variety of barriers we were able to address. And so we analysed this using the Consolidated Framework for Implementation Research, which I will not go into too much detail and bore you with, but the idea that we've used a theoretical framework to categorise this data in a meaningful way, and we've taken that all the way through our research, so it's all aligned in terms of having a really strong basis in implementation science. So I'm not going to go into too much detail about what the barriers that came up from this initial kind of stock take survey, but one example was capacity. So one of the barriers was having enough time to deliver training to all the staff, which could be particularly difficult considering there's competing barriers and already busy schedules, particularly within early settings, and capacity around human and physical resources. So like I say, having enough people to deliver the intervention and having kind of the physical storage capacities to store the supplies. Next slide, Peter. But there are also a lot of facilitators for the implementation of this as well. So again, I won't go through them all, but one was a key one was in terms of including supervised toothbrushing programmes as part of the curriculum, so that it was mandated and had to be covered, and also integrating it with other kind of health campaigns as well. So it had that kind of overall healthy schools, healthy nurseries sort of ethos. So next slide, Peter. However, as I said, this only provides a snapshot of what the kind of implementation challenges and solutions were really, and at this higher kind of local authority commissioner level. But as I've already said, there's lots of different stakeholders involved in this kind of implementation journey. And so we really wanted to gain a comprehensive view of what was happening for all these people and what kind of the key challenges and solutions each kind of group was experiencing. And so we had a whole raft of interviews and focus groups with everyone. You can see at the different levels that outlined at the beginning. So commissioners, your oral health providers, our early year settings, our parents and our children. And I'll come onto the children a little bit later. And we interviewed people all across England to really get an accurate picture of what was going on in terms of implementation. And you've probably noticed there's an extra column of wider context as well, because we realised that there were kind of key areas in terms of education and sustainability that had an impact on the implementation of toothbrushing programs, but didn't necessarily fit neatly into these levels that we'd already kind of created, but could offer really good practice and information in terms of how to implement them in the future. So next slide, Peter. I did say I would get on to the children. So one of the key strengths, I think, of the Brush project is we wanted to have the children's voice from the outset and have it throughout our whole project, because ultimately it's the children that benefit from this intervention. And so we made sure we undertook kind of PPI activities and pilot activities with the children. So we knew we couldn't touch the children in kind of a formal interview way. That wasn't appropriate. So these children are very, very young there. The youngest probably 2, the eldest 6. So we needed to use a method that was really appropriate for them. And we were really lucky to be introduced to a lovely lady here you can see in the headscarf called Hina the Storyteller. And so we worked together to develop an interactive storytelling session. So this allowed us to kind of do 2 things. One, it was a lovely way to kind of give back to the community in terms of raising oral health awareness in the children and delivering key messages. But it also allowed us to test out how we could engage children and get their insight and their experience around oral health and what they would like in a way that was fun and interactive, because we weaved kind of discussion and questions throughout a story that, as you can see, had props and songs and actions. However, I don't think my description does it justice, so I have got a little bit of video so I can give you a little flavour of it, but I won't play it too long. So Peter, can you play the video, please? All right, I'm not sure if the sound's coming through for anyone, but we'll cut it there anyway, because it's just to give you a little flavour of the session. So we ran some PPI sessions with this first to kind of pilot test it out, and then due to the really positive feedback we got from the setting staff, the children and the parents, so we got feedback saying that they had taken those messages home and probably annoying their parents singing the toothbrushing songs at home. We took this forward and used it within our kind of qualitative methods, so we could really get the children's voice. Okay, can we move to the next slide then, Peter? Okay, so in terms of what we found from the qualitative interviews, this looks very complicated, and that's because it's presented currently in terms of the Consolidated Framework for Implementation Research. But just to give you a flavour of what we found, the kind of good news was across all our key stakeholders, they realised that there was a huge problem with children's oral health and that something needed to be done. They were really keen to improve children's health, and actually they had very positive feelings around supervised toothbrushing programs. They knew that it had a strong evidence base, they thought it was quite high quality, and they could see that it could have a real impact on the children. But what we find is there's lots of kind of make and break elements to the implementation of supervised toothbrushing programs, and some of these are quite formal and some of these are more informal. So formally, a real kind of key make or break factor was funding. So you have to have funding for these programs, not only to get them to initially start up, but also to maintain the program over time, so that you're actually giving the program enough time to have benefits on the children's oral health. And this could be challenging, and contracts could sometimes change, and this could be make things more complicated. More informally, it was really important that at each level, all stakeholders were engaged in the programme. And so time and effort had to be really taken to make sure that you were engaging people, you know, from all levels in terms of, you know, recruiting your providers, recruiting your settings, and then engaging your parents and your children as well. So lots of informal relationships had to be built and maintained to keep this programme together, because once everyone was invested and on board, that was when it was the most successful. Next slide, Peter. So we've taken all the information that we've got from our stock take survey and the qualitative interviews, and we embarked on a co-design process. Like I said, with the ultimate goal was always to end up with some form of implementation toolkit to help smooth this implementation journey. And so we held a number of co-design workshops across the different levels like I've described, working with them to make sure that we could provide something that fit their needs. Also, as part of this, we made some really good links with policymakers as well to make sure, again, that it kind of aligned with their needs and wants, and therefore could help with dissemination as well in terms of getting this out to as many people as possible, because we want to help as many people as possible. These co-design workshops were really interesting in terms of they actually identified gaps in the current resources that actually went beyond the existing project and was almost like a pre-implementation level. And so we worked really hard to kind of address this as well within our toolkit to make sure that we were covering all the gaps. Next slide, Peter. And then we started pilot testing the toolkit with key kind of stakeholders again. So we're going to make sure that we definitely, you know, we have something that's fit for purpose. So test it with commissioners, see that it fit their purpose. And also, like I said, we kept children involved at all times. So we developed a range of activities with early years and children themselves, and we piloted them with them to see what they thought of them. Again, you know, this idea of making sure we're getting the children's voice and also including them in this implementation process so that we can adequately prepare them and educate them rather than just dropping an intervention in on them. And as part of this, we developed a case study for Department of Education where we'd tested kind of the supervised toothbrushing programme within an early years setting. And this all comes to the ultimate thing of the toolkit, which I will pass on to Zoe to talk about.
Thank you. So I'm Zoe Marshman. I'm Professor of Dental Public Health and I'm based at the University of Sheffield. So just wanted to just finish off by showing you a few slides that describe the toolkit. So you'll see the website there. This toolkit has been, as Cara said, co-designed very much to meet the needs of those who are trying to establish a new toothbrushing programme or to expand an existing scheme. So you'll see here that across the top, there's a number of different tabs, a number of different areas. We know that the needs of the toolkit are different, whether you're a commissioner, so somebody that's interested in trying to commission, secure funding and procure a programme, whether you're an oral health promotion team or a provider of the supervised toothbrushing programmes, whether you're an early years setting, a school or a nursery or childminder, or whether you're a parent who's just wanting to find out more about the programmes. So you'll find the website there, and please do feel free to have a look. If I just move to the next slide, just taken a few sort of screenshots to show you those areas in more detail. So there's a lot of content. Some of it is new content, but much of it is content that already existed. Much of the content has actually been developed by people that are on this call. So where we've identified examples of excellent practice from around England, and we have use the toolkit as a way of kind of collating those resources in one place. Because when we did the interviews that Cara mentioned, that there was a lot of people that were very interested in setting up new programs, but they felt like they were just having to reinvent the wheel all the time because they were having difficulty accessing resources from successful programs. So there's the different areas as I stated. On the next slide, you'll see if you click onto those, you'll see so resources for providers. So each of those little coloured circles, you can click on those and to find some resources for early year settings. So again, the Brilliant Brushes is featuring heavily there, and we've got Jill on the call and co. Those are there to provide examples for people to download, for people to use as templates. And then there's some of sort of more, maybe some of the other detail that we've got on there that may be appropriate for commissioners. So we know that as part of the Children and Young People transformation, funding that the ICBs have been going through for areas that wanted to establish a new supervised toothbrushing programme, they were asked to develop a logic model, which again is not something that lots of people were familiar with. So we've developed a logic model as an example of what one might look like. Again, all just to try and make it easier for anybody who's in the position of wanting to establish a programme to be able to do so. So there's an enormous amount of resources on there, but there are some gaps, as Cara said, and we're collecting a list of those now. Now the toolkit is live, and that hoping over the remaining of the projects, we've got about a year left of the project, that we'll be able to fill some of those gaps. So the next slide, please, Peter. I've just got 2 slides left. So I just wanted to finish off by sort of summing up, really, and to say that it's an apparently fairly simple thing, running a supervised toothbrushing programme. It's effective. We know it's done very successfully in lots of parts of England, but when you drill down into it, actually to make it successful and to implement it and sustain it, it actually is a bit more complex than it appears, and you need a lot of things to kind of line up, a lot of barriers to overcome, a lot of facilitators to sort of engage. So we're hoping through our work in this area, and particularly through this toolkit, that we've been able to provide solutions to some of the complexities. Some of the complexities are more maybe at a higher level, maybe things you think about, things like funding, or things like the sort of national guidance about infection prevention and control. That's where obviously we need to engage, and we have engaged with some of the sort of policy links that we've made. Cara's mentioned the Department for Education already. We're also engaged with the Office of Health Improvements and Disparities. So one of the things that people talked about when we first started was, well, what about the PHE toolkit? There's already a PHE toolkit for supervised toothbrushing. And we know, we've worked closely with OHID, that they're producing a new OHID toolkit, but the difference being that theirs is the kind of a higher level. It does include, as I said, infection prevention and control. It's had the Health Protection Agency involved in a way that we would never do with our kind of work. But ours is more of a how-to guide that will help regional or local areas implement that national guidance. And that's why it's been really important that we've had those policy links throughout. We've heard recently, and Peter alluded to this, about dental access and dental policies, and the dental recovery plan, and Labour Party's pledge about supervised toothbrushing. And again, we're trying to ensure that the research that we're doing is feeding into some of those policy decisions. And we know that with integrated care boards, the integration agenda, that's also offering the opportunity for this kind of work. So currently, local authorities still have responsibilities for improving children's health, including children's oral health. We know that budgets are tight, but we also know that the ICBs have this kind of integration of local authorities and the NHS together, and that it's the sort of ICB that holds the dental access or dental services budget. So again, we're sort of trying to, through the research, look at ways that by sort of sharing responsibilities, or perhaps looking at sort of complementary approaches that local authorities and ICPs can have, how we can perhaps suggest and model a way of working in future for those areas that, again, are wanting to support this kind of work. So my final slide, please, final talky slide, is just to tell you a little bit about the next steps. So we saw the maps of the first survey that we did showing the supervised toothbrushing programs a couple of years ago. We've just completed our second survey. So just this week, we've completed the data collection for that. So we'll be able to produce very soon a new map and look at where the changes have happened, where new areas have got programs, where programs have expanded. And we're planning to have a third survey, a similar survey in January next year, because currently that information just isn't recorded, and it's the kind of information that that certainly the policymakers find particularly useful. We've mentioned about developing the website content. So, for example, we're going to develop the content in terms of resources for childminders. Had a lot of requests for information about supporting special schools, which again is can be a little bit more tricky than mainstream schools in terms of the level of supervision of the supervised toothbrushing that's needed. And then again, over the next year or so, we're going to try and look at the role that this toolkit has played in introducing or expanding the toothbrushing programs in specific areas of the country. But again, if anybody has any suggestions for how our work can meet your needs better, then that's one of the kind of the sort of priorities of this kind of research. So this research was funded by the NIHR, the Applied Research Collaboration, and very much that applied research means that a lot of what we've done is involved talking to people that delivering these programs, commission these programs, perhaps making policy around these programs. So you'll find a link to our toolkit on the slide. You'll find a link to the brush project page on the NIHR Applied Research Collaboration website. There's a press release there when we launched the toolkit, and really pleased to say to be able to sort of say today that that while the toolkit was only launched in January, that it's already had around 5,000 unique visitors. So we're hoping that those are not one-off visitors. We know that quite a lot of them are visitors have returned. And at that point, I think I'll stop and we'll take any questions. Thanks very much.
That's fantastic, Zoe and Peter and Cara. Thank you so much for that. Has anyone got any questions? What I'll probably do is I'll stop the screen sharing just so we can see everyone. And there's some comments in the chat. Just all positive comments, really. We've had an excellent toolkit to help fill the gaps for different stakeholders, and thank you for all of this work. Sharon Walker's put, she agrees that the inclusion of information for special schools will be beneficial and that it's an excellent toolkit. And Joanne has put that they've been running toothbrushing clubs for a while, but will find the toolkit and the resources really, really helpful, which is great. So has anyone got any specific questions that they want to put to the team today? You've stunned everybody into silence.
That's where email is useful.
Yeah, definitely.
So yeah, please do feel free to email us. And on the website, there is an inquiry section. So if you do have a look around the website and you sort of realise there's a question you want to pose, or maybe notice some resources that are missing, then do complete that. I think we've had at least 40 inquiries via the website so far, and we've managed to get back to most people. Some of it's asking for specific content, some of it's wanting to know the first steps in terms of setting up a toothbrushing program in their area. So yeah, we're actively responding to those queries if people would like to pose any questions to us that way. I think perhaps just worth saying that although this is a supervised toothbrushing toolkit, quite a lot of the process that we've been through may be relevant for other people developing other toolkits for various sort of more looking at these kind of implementation challenges. So hopefully we kind of help to contribute a little bit to that as well. That's
great. And we'll be able to send a copy of the slides around, and we will also put this recording on the YouTube channel as well. We could perhaps link that to your site as well, Zoe and Peter and Cara, in some way. So you've got a recording there that might be quite useful. So everyone will get a copy of that. I think you might have a question in the chat.
Yeah, from Sharon. Yeah, that return on investment data would be, we would definitely like that to be updated. It was done, it was commissioned by the University of York, the Healthcare Consortium, Health Economics Consortium, that original work. So there's a little bit of new evidence since then from Charles Smile. So yeah, that would be great. So we could maybe add that to our list of things to do if any further funding for the project becomes available, because yeah, Sharon, it's a very good point, and there's been other people that have asked a similar thing, and it's the return on investment in terms of comparing, you know, say if you were an ICB or a local authority and you had X amount of money and you could spend it on supervised toothbrushing programs or health visitors or postal survey, a postal toothbrushing pack. So health visitors giving out a pack, toothbrushing pack, or postal survey, a postal toothbrushing pack, or water fluoridation, the return on investment. So I think yeah, it would definitely be good. I think someone called
that the health economics team at the Yorkshire and Humber Arc might be able to help with as well, Zoe, which might be quite nice.
Yeah, it's good. Yeah, definitely.
And Claire, you've got your hand up.
Yes, sorry, it took me, I haven't been on Zoom for ages. It took me ages to find out where the raised hand was. Thank you very much, everybody. I know this was about setting up this sort of intervention, but I just wondered how important parental involvement was. And my other question, Zoe, you mentioned a different toolkit, but I didn't quite catch the one, what you said.
Yeah, so a really good question, Claire, that parental involvement through the qualitative interviews that we did, it was really interesting, because there has been sort of thought that perhaps some parents don't consent, maybe they've got concerns about fluoride, or they might be the other way where parents might think, oh, well, they're doing it at school or nursery, so we don't have to try and do the toothbrushing at home. But actually, it seemed as if parents were very generally very supportive, and felt that because their children were brushing at school with their friends in a sort of supervised way with a brushing song and the resources provided, that it was actually quite sort of complementary to what they were doing at home and made the home toothbrushing easier. And a lot of we've got some of some of it's covered in the toolkit now about the importance of the supervised toothbrushing complementing the home toothbrushing in nurseries and schools, and parents working together to promote both home and early years toothbrushing. So yeah, a lot of positive views from parents. And then the other toolkit I mentioned, it was called the PHE toolkit when PHE existed. So it was Public Health England supervised toothbrushing toolkit. So that was more like the national kind of guidance that said that people should do one, and it talked about the need for a quality assurance program and monitoring, and it had service sort of sample service spec, but it kind of only went so far. It didn't actually tell either commissioners how to get to that stage, or the people that were providing the supervised toothbrushing programs, or those that were delivering it on the ground. It didn't go far enough in telling them how to do it.
Yeah.
So that's kind of where our toolkit, that's kind of why we call it an implementation toolkit, is trying to sort of fill the gaps between what might be the sort of policy and then actually how you do it.
Okay.
And so that toolkit, I'll put it in the chat. It's changed a bit over time, because during COVID times it sort of there was a few changes in terms of infection control, but you'll see now when I pop it in the chat here that it mentions that there's a new OHID toolkit that's due shortly, and that's going through the OHID publication process. But and I know there's a few of us on the call that have been involved in that updating that toolkit, that it is completely complementary to our toolkit.
Okay, thanks very much. Thank you.
That's great. Has anyone got any more questions? Anyone else? If you can't find your hand to put it up, it's absolutely fine. Just yell. It's not a problem. Got a comment in the chat. We definitely found some parents felt toothbrushing at school helped them with toothbrushing at home, but also have to be careful because some parents don't use it as an excuse to opt out at home.
Yeah, no, really, really good point. And I think we've definitely learnt from doing this how important it is. Well, you know, Jill, when you're setting the toothbrushing program up, to frame it in that way, that it isn't a sort of an excuse. It's there to be complementary. And yeah, because of course there's the holidays, there's the weekends, there's when the children, particularly the children are kind of maybe 3 to 6 years, so there's we want the children to learn those skills, and then when they're sort of too old for the program, to be able to continue those skills themselves. So big thank you. Well, I mean, everybody on the call that has contributed to the toolkit, we're most grateful for all the kind of support. We've had a lot of emails backwards and forwards. We've had a lot of questions. We've and had just like to acknowledge everybody's how generous everybody's been with their resources.
Fantastic. Well, if there's no more questions, then you can have 10 minutes of your lunch and lunch back.
Thank you.
Yeah, we'll have the recording on our YouTube channel in the next few days if you want, and then we'll send it around so you can share it with people, and just get in touch if you need anything.
Thank you very much.
Thank you very much.
Thank you.